Hello everyone, thank you for joining. I'm just gonna give a few more minutes in case somebody else wants to join. Then Stephanie can start.
Son como... ¿Qué?
Good morning, everyone. Thank you for joining us to this meeting for the HospitalEscuela Nutrition Working Group meeting that we have been invited to share with you about the nutritional conditions and challenges of children with cancer in limited resources country. We are going to share about the experience in Honduras. Next. First of all, I need to talk about Honduras. We have to describe that Honduras is a country with almost 10 million people, with young people. 36% of their population are 15 years of age and low. 1/4 of the children are affected by chronic malnutrition. Honduran economy is based on agriculture, and natural disasters have a devastating impact. As you know, like last year, we had 2 hurricanes, and there are a lot of damage that are caused by the problems with the weather in our country. Next. We are located in the capital city, in Tegucigalpa. Tegucigalpa is a big city where there is a lot of migration from the rural areas, and there is a lot of inequity because the distribution of wealth is not equal. So there are a lot of, the majority of the population are in poverty. Next. And also 66% of the population live in poverty, and from them, 45% live in extreme poverty. Next. We, in the pediatric oncology, work with, let me see if it's running the slide. Next. No, no aparece. We are doing all the efforts possible to help our people, especially because in our country, when we are talking about pediatric oncology, we are serving the majority of the population that we receive in our country belong to very poor families. We have in the care of our children, beside of the oncology care, there is a local foundation that provides for the families food in a way to prevent from the families to abandon the treatment. This food that is given every month is given not only to the sick child, but also to the complete family, especially if they belong to a very, if they live in very bad economical situation. Next. Our hospitals, what we have done to prevent abandonment of treatment, we have started with oncology wards in the different public hospitals in the whole country. We have 3 main cities in our country, and they belong to the public health system. Our hospital is located in the capital city, Tegucigalpa. Next. Our hospital's name is HospitalEscuela. It is a general public hospital with 2,000 beds, and the oncology ward depends on the pediatrics department, where we have to compete with other illnesses, especially the trauma that unfortunately children suffers because of violence and also accidents. HospitalEscuela is a tertiary level public hospital that is dedicated for children and also for adults. Next slide, please. Just to show you the remodel area for ambulatory care of the children with cancer that was done by the local foundation. It has 6 couches and 11 beds. We have a very busy ward that treats children with cancer. We also have the inpatient area with 22 beds and 2 beds for children with palliative care. Next. About the statistics that we have, just to make to give you the information about the new cases that we receive per year. In Tegucigalpa, in our capital city, we receive about 200 new cases per year. And the majority of the diagnoses that are done is leukemias. Next. The personnel that we have in our ward, we only have 6 physicians, six oncologists, 2 pediatricians that are not only full-time. The ratio between doctor and inpatients are 1 per 25 patients. And in the ambulatory setting is 1 doctor per 9 patients. We have for the oncology ward 44 nurses that are distributed in different shifts. The shift that are taking more care of the children are during the shift in the morning and in the afternoon. During the nights are very few nurses who take care of our children. Until 2019, we didn't have at all a dietitian that could take care of a nutritional program. We only had visitors of the career, the ones that are studying to become dietitians, and they didn't have experience at all. For that reason, next, and because of our relationship with Elena Ladas through IPAN, we talked with her and we had a very reception from her to start as a research project, the possibility to have a nutrition project in HospitalEscuela, and we started in 2019. The general objective for this nutritional program was to start the nutritional assessment of children with cancer in HospitalEscuela. The specific objectives was that the nutritional assessment evaluation through weight and arm circumference of patients and be recorded for statistical data. Also to have intervention from a higher dietitian that is dedicated to the oncology ward, and to have personal training on nutritional care of children with cancer. Next. Data collection of patients, nutritional follow-up for a 3-year period was started and recently extended. Data collected was anthropometry, demographic and clinical data, chemotherapy-induced toxicity, infections, and nutritional interventions. Okay, now what we can say about the problems that we have for research are the need for more researchers, the lack of time for research because of demands for nutritional interventions in oncology work, and always the problem, the lack of funds, because we have to compete with many needs that are in the world for the children with cancer. And now I'm going to present you Ms. Stephanie Celaya Sagastizado, and she is our dietitian who is in charge of the nutritional program.
Hi everyone, my name is Stephanie Celaya and I'm the dietitian from Honduras. So we're going to talk about a little bit about our challenges. For example, me as a dietitian and as a nutritional service. As we have no nutritional status, a diagnosis has a prognostic implication. Will nourish children tolerate intensive cancer treatment better than those who are malnourished. And thus have better chances of survival and lower relapse rate. Nutritional assessment consists in 3 parts: the data collection, the data evaluation, and the interpretation and findings. Okay, as a nutritional service, we need 4 of these aspects. One is the human resource, like for example, the dietitian is something that we need. The supplements, a food service, and a formula area. What a formula area means is that an area that's gonna prepare the formula, for example, for oral supplementation or for enteral feeding, that they can give this service to the, for example, the inpatients. As a nutritional assessment, as a dietitian, we focused on 4 aspects. The first one is the assessment. We focus on anthropometry, biochemical parameters, clinical evaluation, and dietary history. And then we, with all this information, we get the diagnosis. This for the nutritional interpretation and nutritional risk factors. For example, if a patient doesn't have any malnourished, but it has risk factors, we have to focus on this patient and keep monitoring eventually. Then we have the intervention. Here we need supplements, the dietetic plan, for example, in patients that require a dietetic plan, sometimes obesity patients, and the nutrition education and counseling. And after this, we get the monitoring. Well, we have the nutritional evaluation and the follow-ups. Okay, here's a pie chart. In this pie chart, we do, as a dietitian, we do an evaluation and assessment at the beginning of diagnosis of each patient. So each patient that is new diagnosis, we do an assessment to know how this patient comes, what are the nutritional requirements that he's gonna need, if he's gonna need special attention from our service. So here we have that the 64% of the patient, they come in a normal status. So, but this is only on the 2021. But we know that the 36% have one type of malnourished, if they have mild malnutrition, moderate malnutrition, or a severe malnutrition. So we have to focus on this because sometimes the patients comes with a malnourished status. So we have to focus on them because they are this way before receiving a treatment. So we know that a treatment is gonna give them some side effects that's gonna make worse this status on this patient. We have some of the side effects that they require nutritional assistance. So as you can see, we have a lot of side effects here that, for example, the oncologists have to ask a dietitian for the service, and it's gonna ask for help to help these symptoms and to talk to the parents. So what can we do to improve these symptoms? Here we have, here in Honduras, one of the most important side effects. Diarrhea is a problem because if they have three consecutive days with diarrhea, it's gonna be a losing weight, nausea, and here we have a lot of mucositis. Okay, on this table, we have some high nutritional risk diagnosis. Here in Honduras, all of these are a diagnosis that we have and that we know that they're gonna require a special attention from a dietitian. Here, adding to this table, we add the brain tumors because here in Honduras, it's a diagnosis that we have a lot of percentage of malnourished on these diagnosis patients. One of the reasons, for example, is they already come malnourished. They don't come to the oncology ward. At the first, they go to another area where there's a problem with surgery, so they delay the surgery for the brain tumor. So this is a delay. This is a problem because they delay on the surgery, so they have to be a long stay at the hospital. Okay, some of the challenges that we have. And I have known that there are challenges of another countries. For example, as an IPAN member that we work for IPAN, Nicaragua has some of these problems too. First, one is the enteral feeding. One of the problems on enteral feeding is the medical team acceptance. For example, here we have 5 oncologists and they rotate one a month, one for a month, and then they rotate. So this is some challenge because we have different opinions. Even the oncologists sometimes have different opinions if a patient needs or require enteral feeding. Sometimes they say that they don't need it, or we have different opinions as dietitian and oncologist or medical team. The family acceptance is another challenge because here, as a cultural thing, we don't, or family or parents, they don't want to see a tube from the nose of the patient, knowing that they are receiving treatment. So they think that's bad or it's gonna be bad for them, but they don't see the benefits or the good part of having a tube or enteral feeding. It comes the job of the dietitian to make a convincement on parents. The lack of research is another challenge, because here we don't have enough supplements or enough tubes so that we can cover all the needs for the patient. The low nurse support in this part, what I refer is that as Dr. Fu said, there are not enough nurses here to attend the patient. So they administrate medicine. They take care of a lot of things, so they don't have sometimes the time to even take care of the tubes or the feeding. For example, the dietitian here has a schedule, so when the dietitian leaves the hospital, there's no one that can help for being monitoring the feeding. The resources and supplement. There is not enough budget formula. Here we don't have enough budget. We sometimes get the support from the foundation that it was mentioned before. When we have a patient that requires supplements, the foundation gives but it's not always that we get this help. Because of this, it's hard to adequate intervention for not having supplements needed. For example, if we don't have the supplements that they're needed, sometimes we cannot get the 100% of the requirements to the patients. We only can get the 20, the 30, sometimes the 50% of their requirements based on how many formula or how many supplements we have. Talking about the human resource, unfortunately, many hospitals in low-income countries are lack of dietitians. In these settings, the medical doctors and nurses need to be trained to conduct a nutritional assessment. As Dr. Fu said before, this oncology unit had a dietitian thanks to IPAN till 2019. So this is relatively new. That's why we have a lot of challenges, because nutrition in our country especially, it's new. Not only in oncology unit, it's new in the country. So it's really hard to accept the nutritional part. So that's why it's been a challenge. In Honduras, for example, we only have one dietitian, and it's located only in one part of the country. And this dietitian, it's based on the attention on new patient, inpatient, outpatients, and palliative care patients. In an average, a dietitian does an assessment and intervention probably from 150 to 200 interventions a month. So as you can see, it's a lot of work. So for only one person, this dietitian takes care of assessment, intervention, monitoring, and data collection. Occasionally, we have the support of students from the career of the nutrition that can help on this demand of patients. Another challenge is the long hospital stays. A total number of patients admitted at pediatric hemato-oncology ward at 2021 were 121 patients. The average date of hospital stay of patients in pediatric hemato-oncology ward is 41 days. But patient that has stayed longer than 41 days is the 39% of these patients, with a total of 49 patients. Of these 49 patients, the 33% of these patients were presented at malnutrition status. But not only these 33%, some of them, they have lost a lot of weight. They're not malnourished, but they lost a lot of weight. Another challenge is nutritional education. One of the challenges is because they always require to street food. And as you know, these are neutropenic patients, so they cannot buy street food. But here it's really common, and that patients, they always, or the parent hospital. This is a problem for us because then it comes diarrhea, then it comes a lot of infections, and they even have to stop chemotherapy because as a dietitian, we educate the parents, we tell them what they can eat, what's good for them, what they cannot. And but there is a lack of interest from parents. The lack of communication between the medical team and the dietitian. Sometimes we get different opinions, or we are not on the same opinion of something, of food, so that's a challenge because we have to be on the same page. Another challenge is the food service. One of them is the non-compliance of diet from the hospital food service. The food service is the one that brings the food to the inpatients, that prepares, that they have the kitchen, and then they bring the food to the inpatients. Sometimes as a dietitian, we ask, for example, for hyperproteic, high in protein diet. So, but they don't bring that diet. They bring normal food with no, that's normal, that normal food that they bring. So that's a challenge because you ask for something, but they don't bring what you ask for. But this is a problem because of the budget of the hospital too. Most inpatients don't like the hospital food because of the flavor, different reasons, because it's not how it's done at home, etc. But this is a challenge because they don't like food, so they go and buy food out of the hospital. Not enough resources at the hospital for adequate food or requirements. This is what I've said before. Because there is not enough resource for buying, for example, 2 portions of protein that I need extra for a patient. If there's not enough budget or enough resource, that's why they don't bring me what I ask for. Another challenge is the cultural part. I think this is different in every country. But for example, here we have the belief of non-professional opinions for a patient. They even have things that they say, this is gonna cure the cancer, give this to the patient. So that's really hard. Sometimes the myth, for example, here there is a myth that if you eat egg, if you have an injury or something, you know that you need protein to heal this wound. And in here, they say that you can't eat egg, for example. So that's really common that people say, but you know that the egg's good. That's not gonna do a bad for the patient. Another one is the traditional foods. For example, here you can see a picture that this food's called carao. And the patient, they think because eating this product, the patient's gonna heal. So that's a lot, and we have a lot of food that the parents think that's good and not always gonna make a good. Here we have some of pictures of patients that we have recovered or that they were on recuperation. This is a non-Hodgkin lymphoma that it was located at neck. So that's why she couldn't feed orally. So we have to, she had a gastrostomy. So through the gastrostomy, she finished her treatment and she recovered her weight. Here we have a patient with ALL. The major effect that made her malnourished is that she came malnourished, and then she has a neutropenic colitis. So it was hard because she got malnourished, but as you can see, she recovered. She became an ambulatory patient, and she has recovered her weight. Here we have another patient, before and after of a patient AL2, but with a nasogastric tube. So we have a lot of patients that have recovered their weight based on a enteral feeding. So that's why we know the benefits of enteral feeding. Some of the recommendation for improving the nutritional support in oncology unit first is the creation of standardized protocol of enteral feeding. I know there is a lot of algorithms that's gonna help and say, for example, if the gut's not functioning or that they need enteral feeding, but I think that we need protocols that they are standardized for each country, because sometimes we don't have the resources, for example, in other countries where these protocols or these algorithms are made. So I think that could help here, and even the part of the different opinions from medical part and the dietitian. The permanent nutritional assessment, as I said before, we have the dietitian here because of IPAN. So it's not that we have a permanent permanent dietitian from the hospital. Improve homemade food because of the lack of freezers. Here, I can show this is an example of hypercaloric shakes recipes that Maria Carrillo from Nicaragua and myself did. That has a lot of recipes that it can be by oral, or it can be in enteral feed or by tube. And there are recipes that's homemade. So this could help the part of that we don't have budget for industrialized formula. And we made these based on calories, how many calories had each shake. So this can be a good part that it can be implemented. But here in Honduras, we haven't implemented because we don't have an area, especially for preparing these hypercaloric shakes. So that's our part. Thank you for listening. And I don't know if you have more, if you have questions or comment about our presentation.
Thank you so much, Stephanie and Legia, for a very informative talk and explaining to us what's going on in your country. Is there any questions from the group?
Thank you. I hope you have listened to all our presentation. We will be glad to share more. If you have any questions or comments, you are welcome. Thank you. Judy, I cannot hear.
Legia, I just wanted to know the foundation that's helping you with the groceries, the groceries home, and sometimes the supplements. Is it the foundation from the hospital or is it from outside?
You see, the budget it comes from the government, and they provide the meals, the groceries for the patients who are admitted at the hospital. The groceries that are brought to the families are given by the local foundation. It is a very great help that they provide. It's their name is Fundación Hondureña para el Niño con Cáncer. They were created to help with the needs, especially for oncology needs. For example, with the lack of chemotherapy or when we don't have an antibiotic. But since they are aware of the poverty of our patients and their families, they also organize every month the distribution of groceries for the families. And as I tell you, they are shared not only for the patient, but also to the families that they have. That majority, they have more than 4 kids. And you know that there is a lot of risk of abandonment of treatment, because the families, the majority of the time, maybe they can lose their jobs because they have to come very often for the chemotherapy, for the treatment of their family, of the child. So there is a lot of risk in our settings. In our countries, there is a lot of risk of abandonment of treatment. but the foundation, they help them with groceries and also with paying for the transportation of these families to come for treatment to our hospitals. And that was it was also the reason why we opened oncology wards in the other hospitals. It's not that we have that many oncologists. For example, here in the capital city, at least we have more oncologists, but in San Pedro Sula, that is the other hospital, they only have 3 oncologists. And there is another hospital where we only have 1 oncologist. But at least we are able to provide some quality of care in all those 3 hospitals.
No, that's excellent. I mean, you basically support the family, and then you know your patient is there, and just the pictures of your unit, it's beautiful. I can see that it's like you're like a family there. So yeah, that's great. I'm grateful for you guys that we're able to do that. Is there any other questions?
I'd just like to make a comment. Hi, everyone. I work in Brazil, and thank you so much for your presentation. It was really good. I think it's always comforting for us to watch everybody to see a presentation about other institutions and to especially figure out we have the same problems, I think. So that's what I'd like to comment, that every time I see people talking about patients not liking hospital food and bringing food from the outside and family compliance to enteral feeding and the myths, I think it's something that we all have to deal with. I certainly have dealt with a lot of those problems on a day-to-day basis, and it's a big challenge. That it's important for us to know that we all face those same challenges, and maybe we can share some strategies on how to deal with it.
Thank you, Karina. I just wanted to, Jessica said excellent work. Thank you, especially because it's possible to do in countries with similar conditions. We have a lot of challenges. And then Alexandra asked, she's Alexandra from Indonesia.
Hi, I'm sorry I didn't hear your question, Judy, or no. If you said a comment, but I just want to answer to Alexandra. She's asking, how did you encourage teenagers to accept enteral feeding? What we do here is that we have the psychologist. It's a teamwork. So we have the intervention of the psychologist with the dietitian. So we explain the benefits of the two that they require the attention from the psychologist, because it's very important. So to have the teamwork. Mm-hmm.
Is there anybody else that have, this is an excellent solution to work like as a team and spend time with the teenagers. Is there anybody else that have to, I think we all have the same problem with teenagers. What I do is usually with one of the sisters, we go and sit with the child and show them like growth charts where they are at the moment and like make a deal with them. Like if you're at a certain stage in a growth chart, we can take it out. And the sooner you reach that, the sooner you can go home. But you don't just talk and do it. You have to like do it like every day, talk to them and explain to them the benefit, or if they don't want the tube, what else is there to do and stuff. So that's what I usually do. I don't know somebody else. We don't have the psychologists like available. We have one in the whole hospital. So we cannot really ask her to come and help us with that. So that's what we try to do from my side and the sisters. Is anybody else that maybe have something else that they do?
Yeah, well, here
Stephanie,
it's
pictures. Sorry, Stephanie just said pictures. That's also a great idea. We always have pictures of old patients, but you can also do.
Yeah, I think those are all great strategies that we have used here as well. And I just like to comment that as the more you do that, and the more those teenagers are seeing other teenagers with feeding tubes at the clinic, it becomes easier. It becomes more normal for everyone, and not just the teenagers, for everybody, for even the healthcare professionals in the hospital. It's when you're used to seeing it, it becomes more normalized in everybody's eyes, and everybody becomes more compliant to it.
Yeah, that's true. And but I always also realize if you want it put in a tube and it's a new patient, you need to do it as soon as possible, within like 48 hours. Then by like new and by like think it's part of the treatment, but it is. But then by like more agreeable when somebody that's been in a ward for like a month or 2 months. But yeah, I think in my case, I'm fortunate to have doctors that believe in nutrition. So it's part of day one that you actually, the patients are told that nutrition is important. So things might happen like a tube.
Exactly, and that it's part of the treatment. That's very important for everyone to be on the same page. Yeah.